My name is Peter Black, and I'm here talking with Professor Vinko Dolenc, who is the professor and chairman of the Department of Neurosurgery at the University Medical Center of Ljubljana in Slovenia, a newly created country from what was part of previous Yugoslavia. Professor Dolenc is also the clinical professor of neurosurgery at the University of Virginia in Charlottesville, Virginia. Vinko, welcome. We wanted, over the course of the hour, to talk a little bit about your past, a little bit about what you're doing in the present, and then to ask you some thoughts about neurosurgery in general. So perhaps we could begin by asking you a little of how you grew up into the field of medicine and into neurosurgery. Can you say a little bit about your early childhood first?
I think everybody was naughty when was a child, and so was I think. So I was not the best student at the at the beginning. I think in the grammar school, in the primary school, but in the grammar school I already had some thoughts about medicine, and with reading, more specific literature, and coming to the end of grammar school, then I almost decided to go to the medicine because I would like to study something in connection with the central nervous system. Mm-hmm. And because the system there is different. We don't have a college. We have a 12 years of basic education, and then after that you go through an exam, and if you are successful, then you can apply for faculty, and that is medical school or whatever other schools. So I entered the medical school, and I think already at the beginning, or let's say at the end of first year, when I was much more informed about anatomy, and specifically neuroanatomy, then I was pretty sure that I would like to do this.
Well, so it was anatomy particularly that attracted you to the neurosurgical field, or was it also basic science in some way?
It was at that time was anatomy, because physiology and neurophysiology and all these things came later on, let's say on the second and third year. But I was lucky because I met Professor Peter Nathan from Queen Square Hospital, London, who spent some period of time at our institution, and I was his guinea pig. So he put many electrodes on on my thigh, and he was studying the sampling of the muscle fibers. Mm-hmm. And it was really a great stimulus for me to enter this field even more. So I was not sure at that time that I will end in neurosurgery, but in neuroscience is for pretty sure. I mean,
were there any other particularly strong influences as you developed that you think formed a little bit how you are today in your teaching, early education?
Yeah, then I went, actually, I realized that I have to speak English, first of all. When I met Professor Peter Nathan, because in my grammar school I had German and French and Latin, and I realized that it's not enough. That
not many people speak Latin anymore. It's true.
That's one thing. But what is even more important, I think, all of them, they speak English.
Sure.
And the literature is. So then I started studying English, and then I went to England and spent some time there. And before I I finished medical school, we had a air crash. An airplane fell down at our airport, and I was at the end of the study. So I helped to these victims who survived. And why this is important? Because British government and this company, Thomson, they offered us help to the hospital because of somehow good care of survivors. And now the point comes, my old professor, Professor Zhumer, he said at that time that he does not need blankets and those usual things, that he needs microscope.
I see.
And that was something really visionary. So we got the microscope, actually he got it from this company Thomson, and this was another very important situation that I was able to start with microsurgery.
What year was that, Vinko? That is, was that?
This was actually the accident was on 66, and on 67 we got a microscope, and on 68 I started with residency.
So that was very early in the development of microsurgery. You were really at the...
It was very early, and if you recall, Yasha Gil organized his first course, it was 67.
Yes.
So 68, I had a microscope already, and I was able to start working in the lab. Mm-hmm. And then one year later, I started with peripheral nerves.
And at that time, then, you were doing neurosurgical training still, but you were able to develop your laboratory microsurgical techniques during the training time, is that?
You know, this was not microsurgical training as we have it now. Mm-hmm. It was, everything was improvised, you know. I had to take care by myself for microsutures, for micro-instruments, to get one thing there, one thing somewhere else. But the main thing was microscope. So then with help from neuropathology, neuropathology and anatomy, it was possible to establish a small lab in a corner of a larger room.
Sure.
And it was, I think, very, very important.
And how did you find instruction? That is, was the instruction the specimen that you worked with, or were there people who could tell you about things? Was this something that you developed on your own?
Oh, I'm sure you are familiar with the problem, how difficult it is to change the concept which is established. So I didn't dare to enter the most delicate or zones, you see, or territories. Yes. So I started from peripheral nerves. Mm-hmm. And it was easy to get a specimen, a nerve from a cadaver, and then to try to suture it. And at the same time, it was also possible to start with animals, with rabbits and rats. Mm-hmm. And this was really great help.
And did it turn out then that you were able to get a large patient population as well as your experience increased? Was this
this was very difficult at the very beginning.
Yes. Because
they considered that I'm a little bit crazy. And when I delivered a lecture, I remember it was 69. I said we could replant organs, extremities and digits and fingers and upper and lower limbs. They were just whispering to each other. They said, this guy is
crazy.
It's crazy. But I said, why? Look, we can repair the peripheral nerves. We can repair small vessels. And you can repair the bones. Okay, why we wouldn't start with this? But anyhow, it was very difficult. But somehow I caught one by one of from from surgical group, and they asked me to suture a nerve, and then so slowly I built up the volume, and on 1972, when there was first international micro-neurosurgical meeting in Vienna, I had already 20 cases I operated, and this was a real beginning then.
And then you organized at least one or two congresses of peripheral nerve microsurgery as well as a...
You know, this is medical psychology. First of all, they keep the work away from you. When you succeed and you get the work, you build up, let's say, reasonably good volume of patients. They said, okay, now we will give him too much work, so we will kill him in this respect. and I realized this. Then I operated first year 20, then 40, then 60, 80. Then in 5 years I came to the numbers like 150, 160 peripheral nerves per year. I said, come on, this is too much. Yeah. I'm not going to work only on this field. I have to distribute this. And so I started to think about organizing a course for peripheral nerve reconstructions. And so I did. I did organize 4 courses in Ljubljana, and they were international. And at the same time, my aim was also to, because the world was still divided at that time, I tried to bring experts from West and to organize this in former Yugoslavia and to invite younger people from East so they could meet, because Yugoslavia was all the time in between. So it did work in this respect, but not very much. I mean, to appeal people from East. Most participants were also from the West. So we did organize this in 76, 78, then 80, and then later on we included also other subjects.
And although now we can see that peripheral nerve was clearly a wonderful way to get started in microsurgery, why did you recognize that that would give you ready neurosurgical technique? That is, why didn't you start on anterior communicating aneurysms or pineal region tumors? Or that is, how did you have the foresight to recognize peripheral nerve was the area you wanted to work in?
You know, this was for practical reasons. I think surgery of peripheral nerves, this is two-ways road. You go there, you take a graft, you spoil it. I mean, it may happen, but it is not dangerous for the patient. So you can take another graft and nothing will happen. But if you start with aneurysms or start acoustics, this is only one-way road. I realized that at that time already. And I said, I can obtain some skill from peripheral nerves. And I still think this is a good training for younger neurosurgeons. And we had at that time already such a situation, for instance, that Professor Zhumer, whom I consider my second father, who helped me really a lot, he did dissect the aneurysm. And then he said, now you come with the microscope. And then it was just the opposite. It was upside down, you know, as we have in nowadays practice. My residents, they open, they come to the pathology and they call me. But he did this for me, and he said, now you see, with the microscope maybe you can do it better, because he was too old to deal with the microscope. So I started also with aneurysms very early, and it was 1974, 75. And then later on I came also to this cavernous sinus, just because of aneurysms.
So it was getting interested in the problem of managing certain basal or skull base aneurysms that brought you to the cavernous sinus problem.
Yeah, we we had a lot of difficulties with paraclinoid aneurysms, and we lost patients because we were not able to see the structures very well. So I started thinking about removal of the anterior clinoid.
Yes.
And then this was the first step into the cavernous sinus. Then I realized how many tumors we were not able to resect completely because they were partially in the cavernous sinus or completely.
Right.
And so I started with this laboratory work. It was already at 79, and I spent a lot of hours.
Is that so? Once again, you defined a problem, that is the problem of the cavernous sinus and its anatomy, and went back into the laboratory to do dissections on cadavers. Was that the way in which it worked?
That's it. You know, I can draw a parallel. I think that some people they have this talent. You know, they have a good spatial orientation. I don't have it. So I had to go to the lab and back again and again, and I'm still doing this because I hardly can imagine so different positions in 3 dimensions.
Right.
So unless I see it in the lab, I'm not certain. And so I did a lot of cadaver dissections just to get this 3-dimensional orientation, and it took me a lot of time because the cavernous sinus is like a cube, and you have to see it completely. I mean, the whole sinus. Nevertheless, you don't see it actually at the real surgery. You see only one part of it, but you have to imagine how the other parts are situated or related to it. So I spent almost 2 years in the lab.
And how would you work your laboratory time into your over-busy operating schedule? I think this is something that all young neurosurgeons would like to know, how you did it, how you do it. Do you operate and then go to the laboratory in the evening, or how?
Usually I went there in the evening or late in the afternoon, and then I would work for weekends. And it happened sometimes that they closed the main door of the pathology, and I had to remain there the whole night.
You were stuck there, sleeping with the cadaver. Sounds like it. And you would be able. You just felt that you needed to get the understanding that you just keep going at cadavers until you felt comfortable. Was that?
That's true. When we solved the problem of, let's say, paraclinoid or infraclinoid aneurysms, and then I saw that there are aneurysms also in the cavernous sinus, and then we just expanded. You know, for me it was like to go through the jungle, to have a machete, and then to make a very narrow pathway, because everything was new. There were not so many things published yet, and this gave us really some kind of better feeling that we can do this also in human beings.
I think everyone would say that the contributions in peripheral nerve surgery and cavernous sinus anatomy and surgery already have made you a giant among neurosurgeons. What's next? That is there an area that you think you feel yourself drawn toward now, or are you so busy with all the conferences you have to?
You know, so far I did really a number of surgeries in the cavernous sinus, but I'm uncertain. Each case is again a new challenge, and as you know, I published the second book on 89, and I think I have to reissue it now,
really?
Because so many things are different. Just the other day I tried to select some videos for the meeting, and I saw some of my videos from 5 years ago. I said, who did this? This is not acceptable. So what I'm trying to say that we refined some approaches, and our understanding is now more clear and more simple. And I think this is important for this area, to be as clear, as simple as possible. Then you can transmit this to those people who were not exposed to this area. So I still have a lot of work in the cavernous
So there's
sinus.
no question about
I see no more problems than 10 years ago. So I don't know what would be the new.
And do you think that there will come a day when one can really dissect off the cranial nerves readily and have very little post-operative cranial nerve weakness or palsy, even temporarily with this? Is this a matter of better technique, better understanding of the anatomy, monitoring in some way? What do you think the new challenges are?
I'm very optimistic, but I don't see the end of this way and when it will be possible. But at least now we know what we can avoid, what kind of complications we can avoid. And we get more and more patients with early diagnosis. So it means the tumors and the lesions are not so large and not so big and not so devastating already before surgery. So this would be the first step, to get patients before they have significant neurologic deficits. Because this is completely different if you operate on a patient who has certain nerve palsy or just a slight paresis, or still normally functioning nerve. So when we have such a patient, then we have a much better chances that the outcome will be normal or close to that. But the real question for me is how to evaluate the volume of reserve of compensation of a so-called normally functioning nerve, which is not normal anymore, which is already subclinically damaged. And I think for this we need monitoring. And it would be nice if we could say, okay, this nerve is still functioning, so we cannot objectively find a neurologic deficit. But if we monitor it quantitatively, we see that 30% of its function has been lost already. Then we will be able to follow this also through surgery, and it will be the same as, for instance, for statoacoustics, for cochlear nerve and for facial nerve and so on. Now this is how to evaluate and how to then plan the whole procedure and so on. But the other thing which is very important, and we are at the beginning now, how to understand the real anatomy and vascularization of the third nerve. I don't care very much about the fourth and the sixth, because we can reconstruct them. They are only responsible only for one muscle. But on the other side, the third nerve is so complex, and we don't have even the slightest insight to its inner anatomy and vascularization. And that's what is very, very important and will be the subject of further studies. And there's another very important thing also we are studying now together with Professor Parkinson, and these are sympathetic fibers responsible for, accompanying the carotid artery and then responsible for the eye. And is another subject we would like to follow and to study.
Do you have advice for a young person who wants to learn about working in the cavernous sinus? What steps would you say that person should undertake now, if starting?
Now it is, I think the volume of the literature is pretty large already. And I would suggest to go to the lab and to do the dissections. I think that's the only way. This is without seeing, without touching the structures, without turning them around and tilting them. It is no way. I think it's really dangerous to go to the OR and to do this without having experience with the laboratory dissection. And in this respect, I will welcome everybody who is willing to come to our lab, and will try to do my best to transfer what we know.
As we were talking at the beginning, you said that things have changed considerably in your country now in terms of being able to do things more easily and inviting people to the laboratory. Can you say a little bit about that?
Yeah, we have now at our institution we have three projects. The first one is morphological, neuroanatomical, through which all our residents have to go, and they have to spend at least 5 months in the lab to get the very basic orientation about neuroanatomy. Then they have to do their microsurgical course, and so on and so on. So this is one project, and the other project is monitoring. We have a research in this clinical respect. So we do a lot of monitoring, pre, post, and we do also some animal experiments, and we do a lot of perioperative monitoring, because I think this is the most important. This is nowadays neurosurgery, which is not bloody anymore, or should not be. I mean, nowadays neurosurgery should be a sophisticated neurophysiology.
Yes.
And this is the second. And the third project we have is neuroendocrinological. So we were lucky to have a lot of patients with hypothalamic dysfunctions, either from tumors in the hypothalamus itself, or outside, or from the ventricles. So just in this time we are studying this atrium natriuretic protein, which I think has pretty big influence in aneurysms, in subretinal hemorrhages, in tumors, and in surgical dealing with the tissue.
Sure.
So these are three main topics we are dealing with.
I'd like to just change a little bit in the focus of what we talk about to some of your thoughts about neurosurgery in general. That is, first of all, let me ask you, how do you see neurosurgery as developing? Do you think that this is a specialty that is young and has a long way to go? Do you think it will develop in better and better techniques, or a better understanding of diseases, or better handling of tissues? Where do you think the specialty is going?
I think we are facing the most dynamic time, the most dynamic period for neurosciences at all, and of course part of this is our neurosurgery, and I see that this is a very important and very dynamic time in this respect, that, for instance, neurology has changed so much. It's hard to say, but the practice shows us this, that we don't need classical neurologists anymore as they were, let's say, 15 years ago. We diagnose the tumors by ourselves, we diagnose the aneurysms by ourselves. I mean, GPs, they do it. So neurology has turned to, and should turn more to the basic science, and to go more to the degenerative diseases, and to maybe to genetics and so on. And the question is where we have to go. Do we refine our skills? Do we have to refine our skills? Is it the ultimate goal? I think not. I think this is just the skill and the instrumentation and whatever. This is just a help to our activity which we have in neurosurgery. It would be wrong, in my point of view, if we would think, oh, if I'm good in skill, that's enough. It's far from that. I must say that if there is not a tumor, if there is not an AVM or an aneurysm, for instance, then I'm staying in front of patient. I'm feeling like, you know, I don't know what to do. I think we have to use all our skill, all our experience from morphological aspect to understand the physiology, to understand the cells, to understand the interaction between these cells. So I think that there are still areas, morphological areas, we can contribute to neuroscience. But we have to go this direction that we will refine all our methods so far and so good that we will meet our kinds of treatment or possible changes at the surface or inside the cell. Will it be the end of neurosurgery or not? I don't know, but that's the aim. I mean, we have to go further and we have to incorporate other specialties in our daily work as well as in our research, and we have not to be afraid. We don't need to be afraid, because we only can grow more and quickly and in the right direction if we will have the good cooperation with other neuroscientists.
Do you think that neurosurgery should try to develop its own neuroscientific base to understand the hypothalamus, to understand tumors, to understand vascular disease and why aneurysms grow and why there is vasospasm? Or should it leave that to PhDs?
This is a very good question,
yes.
and I'm thinking about this frequently. Namely, something is, we are at the stage now where we face a gap between the cell and the whole composition. So we have I mean, not we, but basic sciences and neurologists and other people, they have a good knowledge already about the cells, but they don't understand us or they don't talk to us. On the other side, we are somehow linked to morphology too much, and we sometimes don't think enough what this morphology does create, what does it produce, what does it mean. So I think it would be the only way would be to bring all of us together. We cannot do this by ourselves, I think. We can do in some respects, but to cover the whole, it would be just duplication, I think.
So you think that neurosurgery, in a sense, is a morphological specialty in itself, and part of it is tied to the structure of the brain and how it can be manipulated safely?
That's right, but it is so nice if for instance, neurophysiologists, they come to our operating theater, and if I can put or you put an electrode on the superior colliculus or on the facial nerve or statoacoustic nerve, whatever, and we can profit, both of us, because we are not skilled and we do not understand that much neurophysiology as they do. They don't know the material on which they are working, because sometimes they are working on books, but it is different. Look, just example, just cavernous sinus. Now I'm studying, and we are studying this now, let's say 10 years already, and we still don't understand it completely. And this is far from that what means final resolution of the materia, of the morphology. So in one side we are still in the 18th century. On one side we are in the 21st century. I think to bring this on more or less equal level, it will be great help for further advancement.
On the same kind of subject, Vinko, the question of the development of world neurosurgery. I think you're a shining example of someone who took an area and brought it forward while not necessarily being from the most technologically developed background particularly, but I think by your capability and skill just simply went ahead of the Americans and Japanese and any other field. Do you have a feeling about world neurosurgery as a specialty? Is this developing into the highly technological areas and not in developing areas, or what is your sense of this?
You know, this cavernous sinus, this helped me really a lot to go around the world and to see many neurosurgeons around the world, and at the same time, if you have open eyes, you see the levels and the standards, how they are in nowadays. There are tremendous differences, you know, there are incredible differences. And there's one thing I would like to point. For instance, I spend a lot of time also in South America. People, they are very smart, and they can do a lot of things, but I think it would be wrong if all of them would go this direction, and they will say, okay, I would like to do aneurysms as, I don't know, Yashagil does it. This is not of course, everything has to be brought to the higher level, but they cannot contribute that much on the aneurysm surgery, because this has been developed already. They can maybe help us, I mean the whole neurosurgical community, in another respect, because they are faced with the neuro diseases. We don't see them in United States or in Europe. They see a lot of infectious diseases in the central nervous system. They see a lot of parasites. They see a lot of malformations. We don't see them, so many. So I think if they could focus in the pathology, they are in the middle of it. They could bring more insight also to this respect, and it would enrich us and them. So to approach the problem from different aspects, and when you don't have enough this pathology, as we don't have, for instance, in our centers, we cannot go as easy and as fast as they could. And this would be my message to them. And I'm telling all the time that they have so much of material and which could be and which should be dealt with. Of course, they need help, and I think we can help in different ways. But the only help is, as the old Chinese saying says, that you don't solve someone's problem if he's hungry and you give him a fish. You have to teach him how to catch the fish.
Right.
And that's it. And again, I think money and economical situation is important, of course. But most important is how we are thinking and what ideas we have, and you know, sometimes simple solutions are better than very complicated. So I'm sure they can help us. They can enrich our knowledge, and we can help them.
So that perhaps I don't want to put words in your mouth, but I get the feeling that your sense of neurosurgery is that it's a specialty with a neurosurgeon and a patient and the patient's disease, and all the high technology may not be completely important always. That is, that fundamentally there's the doctor and the operative field, and that's the paradigm for that.
I think so. The first is understanding.
Right.
And if we do understand the things well, then we can use different tools. Of course, nobody can minimize the importance of new technology, the scanning and a PET scan, for instance, at the very end. But we can do also a lot with CT scan. I mean, it's not necessary to have in each center a PET scan, but we have to be aware that these are only tools which can also help to certain extent for further development and so on, and they do. But we have to guide them. We don't, if we are going to be the slaves of the machines, then it's our end. I think that's the main thing, and that's why I always say to people, oh, don't stop working if you don't have a MRI.
Right.
It's not the end of the world.
And if one comes from a country where the resources may not allow buying MR scans, should there be neurosurgeons? Should there be people who do this very specialized kind of surgery when there may not be enough to provide food for everyone, or to provide...
Oh yeah, that's also very, very important. I spoke once with a colleague of mine from another country, and I said, why we don't organize something and we do this and this in the neurosurgical field? And his answer was, you know, we have difficulties. We have to provide for each person in our country a piece of soap. He tried to tell me that neurosurgery is very special domain in medicine, and it is, first of all, it is expensive, and that, in his opinion, each country cannot afford it. This is the truth, but only to a certain extent, because I think that to deal with subretinal hemorrhages, it is now very widely spread practice, and we cannot say that some parts of the world they cannot have a neurosurgery. I think it wouldn't be good, but the levels will be different. But let's approach to this from another aspect. I served as a chairman of a committee in Europe for 4 years, and that committee was for cooperative studies. You cannot believe, I found such differences in Europe. And it is difficult to say this country cannot have this and this treatment, or should not have it, because the results are bad or not good enough. I think we have to approach this problem from the positive side, and that is that let's create some centers where the patient will be brought together, and where the knowledge will be collected, and where the doctors will be able to come and to get the information and to get the knowledge. So rather to spread the patients and to give the opportunity to each neurosurgeon to have one such and such pathology per year is maybe another way to create centers. And it can be done also in the third world countries. It's not necessary that each patient from Africa will be sent to Japan or to United States. I mean, centers can be created there with their people, and we can go there and we can help them. And so it will be easier for facilities, and also for for teaching.
One of the things I think that you've shown in your own life, Vinko, is the importance of spreading information. That is, I think you may be the most traveled neurosurgeon in the world, I'm not sure, but certainly among the superstars from the point of view of traveling. And I take it part of that is a belief that it is a world neurosurgical community, not just a Slovenian one, not just a European one or an American one. Is that?
You know, I think the world became so small,
Yes.
and I don't feel happy if I wouldn't have connections with so many people around. This is, you know, one thing. But the other thing, which is very important, this is that when you know something what can improve our art or our daily practice, I think it's our obligation to give this information as soon as possible. Now, why I was and why I'm still traveling so much is because I realized that particularly in this domain, in cavernous sinus, I was pushing so hard at the beginning. And I tried to say, this is possible, this is, and then I made also mistakes. I said, it's easy. And then I realized so many people jumped into this field. And then I realized that the method or this kind of activity can be discredited. And then I realized I have to go around and I have to warn now. Please avoid this, don't do this, don't do this. I mean, I feel somehow responsible because I opened the Pandora's box, and now it's so difficult to control it.
Yes.
Not in this way that I would say that who is allowed to do it and who is not allowed to do it. But I'm responsible to say, I had problems in this respect. I did wrong with this. Please don't repeat this. I think this is our responsibility. And in this respect, also I published a book, and I think I have to rewrite it again.
Sure. If you had advice for a young neurosurgeon about how to develop technique, just generally, that is, not so much just with cavernous sinus anatomy, what is again the laboratory the important thing? Is working on animals important? Is observing great neurosurgeons important? How does one?
It is important if you like to teach somebody how to swim, then it's not enough if he is just observing.
He just watches, yeah.
He just watches. It's not enough. So everybody has to jump into the water and start swimming. And if we draw the parallel, I mean, people, they have to have access to manual work, and they have to use their fingers and to create their skill. But of course, as I said, they have to start from the beginning, from there where it is not dangerous, and that's the lab, which will give them the knowledge and which will widen their horizons. And then I think that they have to start on patients, but again, on such pathologies, they cannot harm, they cannot do bad for the patients. So I think only from assisting a skilled neurosurgeon and then to make the opposite is not enough. Young people, they have to have their own volume of patients, and this should be some patients with peripheral nerves, with some bypass, and for this they have to get the knowledge and the skill in the lab. I'm strongly against that somebody will start with aneurysms unless has a skill. And I was a little bit unhappy because bypass surgery went so much down.
Yes.
And I think now it is coming back again in a better selection and so on. This gives a lot of opportunity for younger people, and so does the dealing with the peripheral nerves, which somehow I think does belong to neurosurgery.
Don't be apologetic. Many of us agree that that's the case. Why do you think that that has not been a strong neurosurgical discipline?
I think we were too much engaged in just in intracranial and spinal pathologies, and they just took it away from us. But there are so few. I'm afraid to say this, but this was my experience. There are so few people, plastic surgeons and orthopedic surgeons and traumatologists. They understand the whole loop. They understand only the effectors.
Yes.
And they are looking for instance, the short abductor of the thumb. But this is not. It is incorporated in the whole shape, in the whole movement of the thumb. And unless we understand what is going on at the very top, I mean, on the cortical level, then we cannot understand why it doesn't work or why it does work. And I think we have to, at least we have to work together with these people, or this belong to our specialty.
Do you think that the specialty should try to recreate a peripheral nerve presence in the world, or should try to push hard to do this?
Yes, I think so. I think so, because this is very good opportunity to to train young people, as well as it is very good opportunity to study the cortical functions, the brain functions,
Yes.
As a feedback. And this is, we don't know yet a lot about plasticity and remodeling of functions at the cortical level, but it exists, and we can study this from hands, from fingers, from legs, and in this, the whole loop, we need also peripheral nerves. And if these are taken away from us, then we miss something.
Do you have any comments about the field of neurosurgery in general as we draw toward the end? That is, are there any things that you feel in its relationship to, you've commented on its relationship to neurology. Are there any things that you that you feel that neurosurgery should try to develop in as a field, or any comments about its relation to general surgery, to the other disciplines, neuropathology, neuroradiology, ENT?
Yes. I think there are some patterns. They are in the history, they are in the art, they are also in the medicine, And if you go back, for instance, for, let's say, 30, 50 years, you will see how the things were developing. Some specialties, they were collected together, they were joined, and then again they dispersed. So I think now we are in a situation, in a stage where we have to cooperate. We have to be very close to other specialties. But let's say, as far and as much as we need them, and as much as they can profit from us. I'm against this, that a young person, a young resident, spends too much time in general surgery, because I think it's time when he or she has to study, has to absorb the knowledge from neuro, not just holding the hooks at general surgery. It is important to have the idea how the surgery in general does function, how the resuscitation should be taken because of this, all these traumatological cases, all these what is happening in daily life now. But not too much, not too much. I think the time is so short, and when people can study and are willing to study is so limited, and when they are over this period, they don't go to the books again. So when they are willing to study and where they are eager to absorb the knowledge is immediately after medical school and then in the residency. And if they spend too much time in other departments, not with us, I think it might be of less benefit than if they are with us.
Are there any other comments you would make to a young person or someone who's trying to develop her own special niche in neurosurgery?
You know, I was struggling against general surgery to become independent neuro department, and we succeeded this, and we also succeeded to have our own program, residency program. And what I'm telling to my residents, that they have to develop something where they will be acting in the future. So I don't like to have a neurosurgeon who will be like me, because I'm already old-fashioned. And if I'm going to create someone and to educate someone to that level, what I have, I think it is not enough for the next 10 years. So he himself has to have a project, a research project, linked to nowadays neurosurgery, and then to develop some slit and to see what the future activity will be in this respect. Everybody will work in cavernous sinus after 5 years. It's not a big deal. You just have to learn anatomy and to learn the technique, and that's it. But we have to go further. And there's no end.
And do you think that there are any particular areas that are especially exciting that someone should think about now?
Oh yes, there are, I mean, tumors, benign, malignant tumors. So we put too much in the same basket still. So much can be still done in malignant tumors.
Yes.
And then the complementary treatment will be easier and more successful. Then we can do a lot in restorative neurology. What is again one thing in my opinion, we always try to treat patients so that they will be as they were before the disease, but it is impossible. We are different as we were at the beginning of this talk. Right. I mean, already aging is a process which makes us different. And when you have a disease, then when we eliminate the disease, the patient is never as he or she was before. So we have to try to create new equilibrium, new functional entities to use what is left much better, and then such an individual will be able to function. So restorative neurology, I think, is the way we have to think about. Not to be unhappy if somebody is paralytic or paralyzed. Let's try to use what is left. For instance, in spinal cord, unless we have a complete transection, there is always something left. We can use spasticity.
Right.
And we can maybe reshape and tailor this tissue which is left, and that the inhibitory or whatever influence will be less, and then we can use what is left. So I see a lot of possibilities.
Are there any other comments you'd like to make about your own life or about neurosurgery in general? That is, anything that we haven't covered that you thought we should?
Oh, I think there are many aspects we could talk and we could continue. We cannot talk about everything. What I would like to say is only this, that I'm happy with my profession, and if I would start once again, I would go the same way. I wouldn't go the other way.
Vinko, thank you very much for a wonderful
Thank you
hour.
very much. Thank you.